In this video, I will be covering the most common cause of pain, tension, and tightness in the traps that a majority of manual therapists completely miss, or when they do find it, they end up beating the hell out of it with their elbows, which only makes the problem worse in the long run. For those of you that don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert, specifically for neck, shoulder, sciatica, and hip pain. My focus is on diagnosing and treating adhesion, also known as scar tissue, and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which does lead to a significant increase in overall functioning, flexibility, and long lasting pain relief. I'm also the founder of the Soft Tissue Treatment Revolution, where we teach overworked massage therapists a new treatment system that will allow you to cut your treatment times by at least 50% so you can stay healthy, avoid that dreaded burnout, and help a hell of a lot more people get out of pain for good. All right, so accessory nerve entrapments. I've covered a lot of nerve entrapments, but this one is really important. It's really known as that giant knot in the trap that really never seems to go away. So let's just start with what's the motor function of the accessory nerve. I just said it. It's a motor nerve. It's one of the 12 cranial nerves, and it actually comes out behind the back of the ear, goes down, and it actually supplies motor innervation to the SCM and the traps. It comes out right through there and goes down, and then goes down through there as well. So, why does it get stuck in the first place? So, usually what happens over time, especially in modern society, we spend a lot of time looking down at our phones, working on a computer, not moving correctly. When we do that, the muscles get overworked, they get overcontracted, they don't get enough blood flow, and they don't get enough oxygen. So it actually sends a signal to the brain. The brain says, hey, there must be a problem here. It starts to lay down this stuff called adhesion. It's like glue that gets inside the muscle. Over time, it starts to get bigger and bigger, makes the muscle less flexible and weaker. The problem for nerves are they have to make their way through muscles. They pierce their way through muscles, fascia, everything to get where they need to go. And as that adhesion gets bigger and bigger, eventually it gets stuck to the nerve. Now, nerves are built with about 15% of extra slack to keep them healthy, but then eventually it gets stuck there. And when it gets stuck, it presents with a lot of classic clinical signs. One is numbness, aching, burning, and tension. And what happens is when the nerve gets entrapped, it creates a lot of inflammation, a lot of tension in the area, and then the body really starts to tighten up everything around there as well. So, a lot of people might be like, oh, when I'm looking at them from a postural standpoint, they might have one shoulder up or dropped from there. All the body's doing is trying to take the pressure off of the nerve. It wants to protect the nerve before anything else. So, what I want to include in this week's video is a very detailed demonstration of me treating an accessory nerve entrapment, specifically in the upper traps. I'm going to go through a lot of things, show you how to find it, how to fix it, and a couple just viewpoints and technique strategies to make sure you effectively treat it, because most people end up missing it completely, or when they do it, they're way too compressive and they really beat the hell out of it, and it doesn't do anything. It actually makes the problem a lot worse. So I'm going to link that video up right now. One of the most common areas in the human body to get is an accessory nerve entrapment. So that accessory nerve comes out behind the ear and it comes down through here, and its job is to basically be a motor branch for the trap and a little bit of the SCM. So it gets really caught up right in through here, and any client that you've ever been with, they're like, I just got this knot in my neck and it never seems to go away. It's because it's actually an accessory nerve entrapment. And what happens is people are too compressive on that. The nerve doesn't need a lot of force. It needs like 7 to 10 ounces of force, but in the right direction. Now, where a lot of people mess up is they forget about the curve of the thoracic spine. So what happens is they go straight in as opposed to going at a 45-degree angle, because it kind of curves down like this. So if you go straight in, all you're going to do is get that nerve entrapped and stuck, and it's not sliding. In order to break that down, you got to get proper depth and tension. So first thing we're going to do is anytime we're palpating the accessory nerve, we're going to bring the arm over just like that and have the client just hold it like that. What that does, and kind of drop it a bit, what that does is allows the shoulder blade to get out of the way a little bit and open that up. And the way I like to palpate, I always want to palpate when they're in a little bit of tension, and usually that's in flexion. So what I'll do is I'll drop their head down just like that. And now what you're going to do is you're going to landmark. There's always good landmarks, like very prominent bony parts where you can find stuff. That's the beauty of anatomy. You know your anatomy, you know where to go. And basically what I do is I find the C7 spinous. You can't miss that. And then this is C7 spinous, and then over here is the superior angle of the scapula. And where this accessory nerve gets caught is usually somewhere in between there. So what I'll do is I just kind of run my thumb over, and when it's caught, it'll feel like a piece of string that's caught, and hers is caught right there. What do you feel in there, Joy? Some tension?
Yeah.
So now I found it and I know where it is. And the key here, if the entrapment is occurring right here, what you want to do is actually go just superior to it, because what we're going to be doing is called internal slide, where we set it and then the client goes through a range of motion and it forces it to go there. So once I find it, I don't really leave my thumb off of it, because then I know I'm there and I won't leave it off of there. Now the key is going to be the setup. So you're going to tell the client how you want them to move. She's going to start back in some extension. And then I'm going to have you drop your head down nice and slow, just like that. And they're going to drop it towards their chest. So what I'm going to do now is I'm going to bring it back in extension. Now the setup here is really key. So I have my thumb here just like that. And what I do is I come in at a 90-degree angle. So I'm facing opposite to the wall. Some people go like this, that's not good. Or they're here, and all you're going to do is bleed out some force in there. So what I'm going to do here is the scar tissue's here. I'm going to be just above that. And the first thing I'm going to do, I'm going to come in at 90, and you see how my elbow gets nice and high. This is going to allow me to accommodate for that 45-degree angle in there. Next thing I'm going to do is I'm going to take my other hand, and specifically like the piezoform and the web here, and that's going to go in and basically cover up that thumb and protect that. So I'm here, and I'm in a really good position, and see how everything's lined up, and this kind of gets that line of drive as we go in there. In order, first we got to get depth on it, and my depth is going to be just a very slight lean with my hips in there. And if you're pushing too far, the client will move too much. You don't want that. It should just be enough where you're going in very gentle like that. Then the next thing I'm going to do is I'm going to drop my elbow just a little bit, just like that, and I'm going to kind of pull it in towards my body a bit, and then I'm going to drop a little bit more in a squat. And that's really loaded up. Now the client's ready for me to go through the motion, and go ahead. And I'm just feeling it pull, 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 pull. And as I'm getting more tension, I'm kind of leaning away with my body and down and pulling with that elbow. All of my force is coming through my thumb, but I'm keeping my depth with this other hand. So what I'll do is I'm gonna remove my palm so you can just see it with the thumb, so you can kind of see what it looks more like. So as I'm in there, I get my depth like that, and then my tension is like that. So the tension is a very short set. You want to actually get some tension into the nerve itself, and then it's loaded up, and then the client goes through that motion. So I'll set it up one more time. So we took the time to palpate it. Always palpate it and find it. Never be directly on it. You want to be right up against it. So I'm here and I found it. I'm here, coming at 90. This one comes in and backs it up, and I'm not in a hurry. I'm staying here and I'm very controlled. And the first step, get my depth with that slight body lean, tuck my elbow in, and then I'm gonna do a slight squat to start, and I'm gonna wait a second, and that's loaded, and now I'm gonna have the client go through the motion. And I'm just feeling that pull, and as it gets more, I can get more tension by dropping that elbow a little bit more. And this area is pretty sensitive, so I usually get about 5 to 7 passes on it and then leave it alone. And a lot of times you got to watch the client when they're going through stuff. Sometimes they'll drop their head too fast, sometimes they'll go too slow. So you want to make sure you coach them in the right way. So a couple take homes from that video. Number one is why the elbow is very ineffective. I hate when I see manual therapists out there using their elbow, grinding the hell out of the area and thinking they're getting a lot of pressure. There's two components to correct treatment. First is proper depth, then tension. I always say, think of that nerve entrapment that's caught in all that adhesion as like a rubber band that you eventually have to break. Now, we could put that rubber band on the ground and we could jump on it, we could rub our elbow on it, we could drive a car over it. It's not actually going to break it. We want to get just the right amount of depth, then we want to get tension to break that down. And when you're using your elbow, you don't have any feedback about what's going on, and all you're really doing is just jamming that nerve entrapment into the area. In the short term, it does create some temporary pain relief because what it's doing is stimulating what's called mechanoreceptors. And basically, they start to fire and they go crazy and they block a little bit of pain. So you don't notice it as much, but it's actually not an effective treatment. Treatment must be safe, effective, and durable. Using your elbow is, I don't think it's safe because you're crushing the nerve. Effective, yeah, maybe you're getting temporary pain relief, but it's not durable. That problem's going to come back right away. Next thing I always want to teach people is the idea of like slowing down. I think a lot of treatment is more what I call like a shotgun approach. You just treat a bunch of things and see what happens. You might do some deep tissue work, then you might throw some cups on there. You might do some taping. You might do some corrective work, but you're not really getting to the root cause of what's going on. You're just throwing a bunch of stuff in and not knowing what's really going to work. What I teach is more of like a sniper approach and slowing down and being deliberate. So one thing we do is we find those landmarks. When we're finding that accessory nerve, we find the part of the superior angle and then over to C7. And we know when we're in there, we're going to find it somewhere, especially if we've taken a thorough history and we know exactly what's going on. Next thing is why the thoracic spine is a little more tricky to treat is because it has this different curve. The cervical spine and the lumbar spine are more what's called lordotic, where they curve a different way. The thoracic spine kind of curves back to account for the ribs. So the angle on that is a little bit different as well. Because if you go just straight in and down, you're actually going to get too much compression and too much depth. You got to kind of go at that 45-degree angle that's going to kind of line it up. And you see how I line it up with my elbows and my body drop in this position. It really allows to accommodate for that curve. And another thing is it's always slow. It's very precise. It's very focused. I'm not in a rush. I teach this idea of like doing a shorter, more effective treatment. So in a normal treatment, I might do 5 to 7 passes on that area. I'm not in there just kicking the hell out of the area. I'm getting the area that needs the most effective treatment in the shortest amount as possible to allow for adequate healing and allow that treatment to hold. So I'm not in a rush. I'm slowing down. I'm making sure my body mechanics are right. I'm making sure my process is right. I always say it's kind of like a pilot taking off. They don't just go right in and floor it or whatever they do with the throttle. They slow down, they make sure everything's right, and they do that. I want to teach you that as well about being a soft tissue provider, being more focused, precise, and slow. And lastly, nerve entrapments are just really the most important thing that you need to treat first. I teach this idea there's 7 problems in the human body: a bone problem, cartilage problem, disc problem, ligament problem, nerve problem, soft tissue problem, and tendon problem. But the thing is, when the nerve is entrapped, it tightens everything up around there and it creates what's called protective tension. So we can do all this other treatment in the world, but if we don't reduce or eliminate that nerve entrapment, that problem is going to come back and it's not going to hold in there as well. So we need to treat the nerve entrapments first, then treat all the other surrounding soft tissue to make for an effective, long-lasting, and durable treatment. So that's all I got for you guys in this video. If you're struggling to figure out exactly what is going on with your client's injury presentation, you feel like you're, I guess, just stuck guessing and always on a path to try to learn some new type of advanced technique, only to be stuck in the same loop of what I call winging it and trying more stuff, then go download our free training modules that help change the way you critically think about figuring out the issue and treating in a new way that gets long lasting results, and get on the path to being a true problem solver. Links to that can be found in the description box below. I appreciate you guys watching, and I'll catch you on the next one.